Okay, good. The art of developing maintenance patients, it doesn't help by accident. I love this part of the presentation. I love doing this in my office. It's an exciting part of what we do because it's the way that I tell the chiropractic story. So it all begins setting the stage for lifelong care. The beginning of the discussion occurs at the report of findings, doesn't it? So when Dr. Binder's patient that we saw the record for with diffuse degenerative changes, spondylosis, stenosis, does anybody in this room believe that this patient is going to go through a course of active care in his condition completely resolved? Absolutely not, right? So we know if this patient, once they went through his clinical trial to see if they would respond, once they did, this patient is going to need some ongoing chiropractic care. So my expectation is Dr. Binder was very honest and upfront with that patient. So hopefully the other chiropractors were like that too. So they went through the clinical trial. Once they got to that point, then it's a matter of educating them on the fact that once we get this stable, then we're going to need to figure out how we're going to keep it stable. So make sure you begin that process at the report of findings. And the report of findings, let's see, how long is your clinical report of findings with the patient, do you think? 3 and 5 minutes, a very comprehensive 3 to 5 minute report. Report of findings. 2 to 3 minutes. 5 minutes, okay? Some of you, I remember doing 45-minute report of findings. I put my patients to sleep. I mean, you guys are half asleep and you've had to listen to me for 6 hours, but remember that. They want to know some basic things. Again, we've got limited time. You want to get to the point. But again, it's very easy to start talking to them about long-term care. It doesn't have to have a long story. It doesn't have to be a long videotape, but it has to begin to plant those seeds at the initial visit. Interestingly enough, I mentioned I was in Colorado Springs a month or so ago. I met for coffee one morning with Bill Esteb, and we had this conversation. The guy who sells videos, you know. And we had a very interesting conversation about it, but his whole purpose is not everybody can communicate long-term care. And so he gives lots of great resources, videos, but also great a report of finding sheets, as well as forms that you put up on the wall or charts and so forth that help with this process. But it does need to start on the first visit. Table talk as they progress, reminders of their progress and what took to get better. So I look forward to that first day they come in here and saying, hey, I'm feeling better. I don't ask a lot of questions. Usually as the patient walks in, docs, I'm sure you experienced this, as they get up from the hot seat and they walk in, you see they got up out of the chair a little bit easier, they're walking in a little bit easier, they're able to tolerate the treatment a little bit easier, and I'll say things like, you're feeling a little bit better today, aren't you? Oh yeah, I'm feeling better. Or I know it's early, are you starting to have any progress? Are you starting to feel any better? Yes or no, it really doesn't matter to me. Don't worry, just hang in there. The more we treat it, the better you're going to feel. Okay? Or if they're feeling great, again, I used this example earlier. Now that we've gotten rid of the pain, let's focus on the healing. We don't ever want this to come back to the way it was the first day that you came in here. So that's another thing. So you're just constant table talk, talking to them about long-term care, healing, stabilization. Pain is not a good motivator past the first few visits. Okay? Educate at the progress exam. We talked about this earlier. Talk about the functional improvement, what they're able to do. I'm glad you've gotten back to the tennis court. Don't get crazy, okay? Why don't you just play tennis once a week? You start adding all those things. What's important to me is not only that you're feeling better, but I need you to be stable. Big difference between feeling good and being stable. I say that 1,000 times a week, okay? More table talk to keep them informed, weekly reminders of how they're doing. I like to do that a lot at the end of the week. So at the end of the week, we'll start talking. This has been a good week. You've done very well. Thank you for being such a good patient. They've come to all their care. If they haven't come to all their visits, then I'll say, we really missed out on one of those visits this week. We need to make that up next week. wait a minute, you only had me scheduled to come in 2 visits next week. Well, you're missing the point. We've got to get this to stabilize, and we missed an appointment this week. Let's make sure we get on track. I'll see you on Monday. We'll see how well it goes, okay? And then I give them weekend instructions. So make sure you're constantly talking to your patients when there is. And then wrapping it all together, last day of active treatment, they should already understand that additional care, maintenance, and supportive care is highly recommended and why they need it, and that they must pay for it, okay? We have them come in for that final exam. It's very methodical the way we do it in our office and how we articulate it, and I'll talk a little bit about that. And let's not forget where those maintenance patients come from. They don't just come in as maintenance patients. They come in as insurance patients. We walk them through that active care, and then we have the opportunity to turn them into maintenance patients, supportive care patients, long-term wellness chiropractic patients. So that's the good thing. So insurance is almost access. It's getting patients into your office. You work through that care, and then you make sure that you turn them into long-term patients. Okay? So insurance contracts give us access to those patients, which is true. So this is how it works. Let me see. Let me just go back here. So in my office on the last day, again, you guys know that I make a big deal out of the progress in re-exams, okay? It's a scheduled appointment. I always tell my patients, on the next visit, we're going to do your re-exam. You've done very well. In fact, I usually like to wait 2 weeks before we do that. And at that time, we're going to talk about a few things. Number one, what you need to do at home to keep yourself stable and keep yourself well. And number two, what you need to do in the office to keep that way as well. So they leave the last visit before they come in for the re-exam, understanding that there's a component of doing things at home and also in the office. So then they show up. What are they going to do? They're going to fill out their outcome assessment forms, right? They're going to do any type of forms or information that you need. I come in, I do a reassessment with the patient. We look at the outcome assessment forms. We make a clinical decision to release them from care. So my staff knows this is going on. If we've got a re-exam scheduled, then they know what they need to do. I know what I need to do. So then the patient comes through, goes through that process. I sit them down. I walk around. I say, Sally, you've been an absolutely terrific patient. You've done everything I've asked you to do, and that's why you are well today. And, of course, then they'll say something, oh, you're a great chiropractor or something like that. But you focus it back on the patients and them following through with the recommendations. So I want to make sure that you never go back to where you were the first day. And, of course, they're all eager to find that out. So there are 3 things that I need you to do. I need you to continue to do the stretches that we taught you how to do. I need you to do the exercises. For some patients, I just need you walking 20 minutes 3 times a week. Some other folks are in the gym. We've given them specific things to do. Whatever exercise routine we've given to the patient, we reinforce that at that point. And then the third thing is I say, the last thing is you need to keep this adjusted from time to time so it doesn't go back. And then I kind of stop and kind of listen to what they have to say. They'll ask me questions. Most of the time they say, yeah, that sounds good. When should I come back? In a month? 2 months? And I'll say, I don't know yet. And I say, let's go ahead and see you in 3 weeks and let's see how well you do. I say, it doesn't really matter to me whether I see you once a month or once every 2 or 3 months, as long as when you come in, you're stable and you're feeling well. Okay? So at this point in my practice, I have more patients probably coming in every 6 to 8 weeks for supportive care than I do once a month, because they've just been under supportive care for so long. And then I have some patients that come in every 2 weeks. So it is what it is. It's just based, we talk about basing our care on good clinical evidence. That's what I'm trying to do with my maintenance care. So the other thing that as my patients start coming in under maintenance care, this is the other thing. You lose some of those patients because they get bored of coming in. They never feel pain. So that's why you've got to keep on track of it. So if they're coming in once every 3 weeks or once a month or whatever it is, they come in, they're doing remarkable, then say, Sally, you're doing great. Let's wait 6 weeks. And by the way, whether it's 4 weeks, 5 weeks, or 3 weeks, if you start feeling uncomfortable or not well, then just come on in. We'll take care of you. It doesn't matter whether we see you every month or every 6 weeks. As long as you're feeling good, that's all that matters to me. And then all of a sudden, you've got your patients, you're on their speed dial. So in 5.5 weeks, or if they're coming up to a weekend, they're walking in my office, they're coming in to make sure they get adjusted. So they become a team player in their maintenance care. And again, they're not stuck to a schedule of once a month. And it's actually the clinically necessary amount of time that they need to be in the office. That's a great maintenance practice. It's a great supportive practice. It's worked for me. There's some other things that we try to do. We have forms. I also started doing videos, or short videos. I do short little video casts that are 45 seconds to a minute. So when a new patient comes in, along with their initial link to fill out their initial paperwork, they have actually it's a 52-second video of me welcoming them to the office, talking about, by the way, referral, how they were referred into the office, and so starting to plant some of those seeds for wellness and health. And then we do it at the first progress exam, and then we do it before the first re-exam. So again, driving the point home that we're here for their long-term health care goals. So that's been helpful as well. So then they walk up, staff, this is what you're interested in. So that's all well and good, Dr. Sharp, but then I got to sit there and I've got to explain to the patient that it's a non-covered service. So what happens in our office is the patient walks up to the front. As soon as I open the door, I work out of one room. This means the patient's been released from care today, all right? And I'll see him in a month or 3 weeks or whatever it is. So we use hand signals in the office. And at that point, my staff knows exactly what to do. And they pull out what? They pull out the H&S waiver that they have right there. And on the back of the waiver is this document here, or this is the waiver here.
Those are in your handouts.
Yeah, and these are in your handouts.
And they're on the website.
But on the back of it, we have an explanation of the maintenance care. So my staff comes up and says, congratulations, you've been released from care. Dr. Sharp wants to see you in a month. What's the first thing that they do? They schedule the appointment. And then at that point, what they do is they talk, well, not today, because I hear this all the same intonations. Not today, but when we see you in 1 month, that'll be your first maintenance visit. And your insurance does not cover maintenance care, so you'll be on our cash plan, which is $55. And that's when she stops. Now, sometimes you get a little pushback, but Tara understands, and for that matter, Ashley, my other CA, understands. So if somebody says, well, I've only used 15 visits, so I've got 5 more to use, then Tara will say something like that. Yes, we'll be able to use those if you have a new injury, but they don't pay for maintenance care. Or sometimes she'll say, we're going to save those in case you have another injury, and we can use those, but they don't pay for maintenance care. So as you start articulating, you change the way they think of their care, and that's worked out very well for us. So we don't have much discussion. Do some people, especially those Affordable Care Act $10 copayment plans, they're not really excited to go to $55. But guess what? It is what it is. I'm not going to sacrifice my contract with H&S to make $45, or to violate my contract. So, okay? So that's what we do, staff. My staff does that. If the patients have any more question about maintenance care, they roll over that form, that waiver, and on the back of the waiver is what you have is the description of what maintenance care is. And so let H&S explain that for you, okay? Have your patients read that. This is the thing. Some do, some don't, so what? So some of your patients are going to become great maintenance patients. Some of them aren't, and you just got to move on. Some of those that don't continue on with care will come back later, what I want you to be is consistent and honest with your patients throughout the course of care. Once you make one small little crack in the dike, once you make one small concession to the maintenance care, it never ends. Okay? Because everybody that they refer in, everybody that they know, they understand, they just got to press until you give in and start charging for maintenance care. The good part of it is once you get over that hump, it's easy. It's very easy. Your patients are fully engaged in the wellness process, and you don't have to worry about this until they have a new injury. And then you can put them back if you need to start a new treatment plan, establish new goals, and put them back on, then you're good. And again, some of my patients will come in or they'll call in and say, I think I need to go back on my insurance. I have a new injury. And what's Tara say? Tara says, Dr. Sharp will make that determination. We'll just have you see the doctor before we do any therapy, and I do a reassessment, and I decide whether we're going to do that or not. Okay? So staff, don't get into an argument about that. Let them know that the doctor will be making that determination. All right? Questions? Well, good, good. All right? Yeah.
I've had a patient that was referred to me from the VA,
Right.
and I've been having trouble getting paid from them. And part of it was because I didn't know I was supposed to file it like Medicare.
Right.
And is there anything else?
Yeah, the question is about the VA patients. How many of you have been seeing some of those, getting some of those referrals? Have you gone through the same process? Or are you getting paid well? Getting paid well? Okay. So we made the mistake of billing them incorrectly the first time with one patient. And then we figured out, because once you do something wrong in that system, it is virtually impossible to get it fixed. So, but eventually we got paid and everything went well, and they paid pretty well. But it's just a matter of learning how to pay, and you just have to be persistent with them. But they will pay those claims. Okay. Well, a little differently.
How do you find out how to file them? Is there any guidance we could?
Yeah, actually the NCCA has a good resource on this for the
Wonderful.
Veterans Plan, and I've only done a few of those, so I'm not going to get in real heavy to it. Who's done a lot of those? Has anybody done a lot of those? You know what? This gentleman's just volunteered. Did you see his hand up? He's volunteered to be your resource for that. So if you wouldn't mind chatting with her when we're done today, that would be great.
Or check the NCCA website.
Yeah,
it sounds
yeah,
like.
and look at that resource. There's a Veterans Committee, but where do you practice at, Doc? In Chapel Hill, and you're seeing a lot in Chapel Hill? Great, great. We've got a few of them. We have a VA facility in Winston-Salem, and we're just having a hard time tapping into that, but that's okay. Okay. Okay, great. So there are other opportunities. So here's a great resource for new patients. We certainly want to serve our veterans and take good care of them, and they deserve good chiropractic care. Took a lot to get to the point, a lot of legislation, a lot of lobbying to get to the point to have access to these patients. And I know we've got an office over in Durham that does that as well. So, any other questions on this? Again, staff, I would suggest you use these resources. How many of you are burning up waiver forms in your office? Not doing them at all? We do waivers every single day in our practice. If you're converting patients over from active care to maintenance care, they must be using a waiver. I had a doctor call me the other day, longtime H&S doctor. He asked me about this. I said, do you use the waiver? He said, what waiver? Okay? So that makes me nervous, okay? So make sure you're using those resources, using this letter to put on the back of that so you can better help explain what maintenance care is all about and what it's not, okay? A few more minutes. We want to go through these last few slides, and then we'll be done. What procedures are being done that you're not being paid for? Are there procedures, services, or products that the doctor wants to add? And review new contract fee schedules to make sure you're using them to your advantage. Again, these are just simple little things to you to do. Develop an easy way for the doctor to communicate procedures to the staff. Again, making sure you're getting everything that you're doing billed and paid for in your office. And review EOBs to find unpaid codes, underpaid codes, etc. Does the doctor review EOBs regularly? I recommend, docs, from time to time, you're looking at your EOBs. You know, you're getting 3 EOBs from H&S a month, and that covers 3+ payers. And so that's an easy one to look, and you get to the point where you can look down pretty quickly in the right column. And when you see zeros, why are there zeros there? Is it a deductible? Was it filed incorrectly? Whatever it is, you need to be on top of that. The other thing, what are we seeing now with some of our H&S patients? The Affordable Care Act patients that don't pay their premiums, and we get those EOBs back and they're not paying the claim. So that's something you need to be on track of, staff making sure the doctor knows that, communicating that to the patient as well. Okay? Good. All right, let me go through, and I want to go and finish off here with one more thing, wrapping it up. And again, a review of H&S's philosophy of care, and hopefully we've articulated that throughout the day and made that clear. It's consistent with all we've discussed. Treat and release. Provide care to correct the presenting condition, bring the patient to maximal medical improvement, and discharge the patient from active care with appropriate instructions regarding maintenance and supportive care, self-care, and prevention of future occurrences. H&S believes that our patients deserve that, deserves care that is accessible, safe, effective, cost-efficient, and considerate of their values and preferences, and respectful of their time and their resources. H&S also believes providers should be able to make treatment decisions based on their own clinical judgments. I appreciate that, don't you? And providers have an obligation to provide medically necessary health care services to health plan members, but also have an obligation to provide care in the most cost-efficient manner. Healthcare plans, insurers that pay for care expect services rendered to their members by contracted providers to be provided consistent with their corporate medical policies and deliver cost-effective care. Very important. And just kind of closing thoughts, the time is now. There's a professional and personal responsibility for each individual chiropractor to take their documentation, practice, administration, and patient care to a higher consciousness and level of competency. This cultural obligation will either be determined by chiropractors or the payers. That cultural authority is now in our court, but will ultimately not be if we don't move forward and quickly with what we do in our practice. So the point of that is just that those of you that are here, I appreciate you being here and listening to this information. Really appreciate H&S providing this venue so we can learn to do a better job. I'm a better chiropractor every time I teach this or I attend one of these seminars. I want to continue to improve what we do in our practice. We've talked about CMS, the OIG reports. There are a lot of things that are kind of working against us, PQRS reporting. We've been given an opportunity in the profession to really drive what's going to happen in chiropractic. And now we've got an opportunity with CMS. We're going to actually be vetted and determined and ranked based on our ability to document, code, and efficiently and effectively see patients. So you've got to embrace this information, make sure you apply this, make sure your staff understands this, so we do an extra good job in our practices and continue to propagate the profession of chiropractic. So with that said, I'm going to pass it back over to Parker.
Please help me thank Dr. Sharp.